Welcome everyone to the third of 3 seminars that we've been giving this week in regards to the epidemiology of the COVID-19 pandemic. We've had presentations this week focusing on various aspects, sociodemographic characteristics, who is most impacted and the reasons why they're most impacted. We've heard from the county on Wednesday about what they're doing, Montgomery County, the health officer and the chief epidemiologist, what is being done within Montgomery County to address this pandemic and the why and sort of the next steps. Today, we're going to be hearing from Dr. Hongjie Liu. Dr. Hongjie Liu is the chair of the Department of Epidemiology and Biostatistics here at the University of Maryland, College Park. He is a trained epidemiologist from California, and he has had some experience working with previous pandemics that I'm sure he's going to be sharing a little bit more about that experience. He teaches advanced methods in epidemiology and is an infectious disease epidemiologist. Dr. Liu, I understand that we're going to see a short video first, a welcome from our dean.
Hi, I'm Dean Boris Lushniak, and welcome to the special seminar series on the epidemiology COVID-19. This is an incredible moment in history for us to be tackling the pandemic of COVID-19. And what a great opportunity for us to be able to work together and to educate each other on the pathways ahead. First of all, thank you much to the organizers of this seminar series and for having this forum for us to be able to exchange ideas. Over the next few days, you'll be listening to experts in the field who want to have an interchange with you, an exchange of ideas with you through the webinar that we're presenting now. In the next few days, you'll be hearing from Dr. Olivia Carter-Pokris, part of our faculty here at the University of Maryland. You'll also be hearing from Dr. Travis Gales and Chung-Fu Liu from the Montgomery County Department of Health, who are out there in the front lines of public health action against COVID-19. And then finally, you'll hear from our esteemed chair of the department, Dr. Hongjie Liu. So this combination is not just about that foursome presenting to you, but it's the interchange of ideas in the midst of a public health crisis. We learn from each other. So let's utilize the seminar series to get better at what we're doing. Thank you very much for attending this, and let's learn together.
Thank you very much for sharing that video and welcome from our dean. I want to remind everybody to please place your microphone on mute so we can hear the presenter. We're going to be holding questions into the end of our presenter's presentation, Dr. Hongjie Liu, our chair. So if you would like to ask your question and make sure you don't forget your question, you can take advantage of the chat box to post your question, and we'll try to get through as many questions as possible. Now, I notice we have a large number of people participating today. If you missed the presentation on Wednesday by the Montgomery County Health Officer and Chief Epidemiologist about what they're doing at the front lines to address this pandemic, or missed my presentation talking about the disproportionate impact on the Latino community, as well as how epidemiologists are contributing to addressing this pandemic in general. You can locate the slides as well as the presentations and additional resources on the website advertising this. So please take advantage of those existing resources. We also intend to have the video for this particular presentation available for future viewing. And down the road, we're going to be advertising additional seminars to talk about the impact of the pandemic on other aspects of societies within the Americas and beyond. So welcome, Dr. Liu. We look forward to your presentation.
Well, thanks Olivia and our dean for the nice introduction and opening remark. Good morning, everyone. Thank you again for your participation. At the very beginning of the epidemic, our school set up the COVID-19 projection team led by Dr. Dushanka Kleiman, and who is Associate Dean in the School of Public Health, also including Dr. Luisa Franzini and Michael Boudreau and myself. Basically, the purpose of this team is to use epidemiological approach to predict the epidemic at different intervention scenarios and also provide public health suggestions and advice to the local health department for the selection of the best intervention and measures. And so far, our team has submitted a total of 10 reports to the county health departments and Maryland state departments. There are 3 phases in the modeling and evaluation. In the first phase, we model the epidemic trends and different intervention scenarios. Basically, we use a model to tell the health authorities what are the best intervention measures the county should use in order to prevent the epidemic. In the second phase, we evaluate the effect of social distance on the disease burden of the epidemic. Now in phase 3, we are going to assess or evaluate the quality and the effect of contact tracing on the epidemic. So once we have data, we move to phase 3. Now currently we are still in phase 2. Now our team follow this principle to model the epidemic, meaning we use modeling approach to help local health government to select the best and effective intervention measures and different epidemic trends. And we do not predict the number of cases or the peak of the epidemic. We just follow the principle promoted by these 3 giant modelers in the world. This is the famous triangle model of infectious diseases. You can see that the occurrence of infectious disease is determined by host, human being, agent, for example, virus or bacteria, and the environment in which we stay in. It is very hard for a model to predict the number of cases and the peak of the epidemic, because the model could not predict the change of human behaviors and the change of environmental factors. It is human behavior that largely determine the scope of the epidemic. Now, before I move to the next part, I'm going to introduce you the basic reproductive number or not. You heard this number almost every day because it is this number that determines the scope and the speed of an epidemic. So basically, R naught represents the average number of susceptible individuals an infected person will transmit the virus to. Now, for example, in this example, R naught equals 3, meaning during an infectious period, an infected person can transmit virus on average to 3 close contacts. For example, I am this guy who are infected with COVID-19. I can transmit virus to 3 contacts out of the 5, and this is wave 1. In wave 2, one of the 3 infected cases from me can transmit virus to other 3. So in this way, the epidemic keep going based upon the waves of transmission. The basic reproductive number has 3 parts. The first one is the number of contacts per day, meaning how many close contacts I would contact as infected cases. The second part is transmission probability per contact, meaning how likely I can transmit the virus to my close contact. And last one is duration of infectiousness, meaning during what period I am able to transmit virus to others. In a susceptible population, when R naught greater than 1, indicating an ongoing epidemic, when R naught less than 1, indicating an epidemic died off. And this, our public health measures should reduce R naught so that it's less than 1. Now, this is a model we use to model the epidemic trends: susceptible, exposed, infectious, and recovered. Is called SGI model. I'm pretty sure you guys have heard this term. So basically, at the very beginning, everybody is susceptible to COVID-19, and which is true because we do not have antibody in our system. Now, at this rate, a certain susceptible cases would be infected. So this compartment called exposed compartment, meaning when virus enter our body, our immune system fight against the virus. At that point, infected cases could not transmit the virus because the virus could not produce in our body due to our own immune system. So that period is called latent period. However, unfortunately, later on, our immune system is defeated by virus, so that virus can grow rapidly in our body. At that point, the infected cases become to be infectious, meaning he or she can transmit the virus to others, which is in this compartment. And after a certain period, a proportion of infected individual would be either recovered or died of the disease. Now, because of the infection, people may get antibody to protect ourselves against the second infections. There's no room from recovered compartment to susceptible compartment. And this model fits the natural history of COVID-19, and that is reason we use this model. So basically, we use these mathematical equations to estimate the number of cases and different intervention scenarios. Now, in order to use a model to predict epidemic trends, we need to estimate modeling parameters. And this is key part in modeling. If you select wrong parameters, you cannot predict the epidemic. So in SGI model, we need 4 parameters. Number 1 is size of time step. We select 1, meaning we try to estimate number of cases per day and total population size. This is total population size either in Montgomery County or Prince George County, because we're assuming at the very beginning, everybody is susceptible to the virus. The third one is average pre-infectious period. The fourth one is average duration of infectious needs. And we put 3 days as pre-infectious period and 5 days for the average duration of infectious needs. These 2 days are commonly used in the epidemic of COVID-19. We just simply use these 2 numbers. Now, the last one is the most important one. We need to estimate basic reproductive numbers. Now, previous majority of models in the United States use the value of R0 estimated in China. However, the epidemic in China is totally different from the epidemic in the United States, meaning the scope and scale, the speed of epidemic in China differ from they are in the United States. Therefore, we could not use R0 estimated from other countries and apply them to the local epidemic. Now, consequently, we estimate R0 based upon the local epidemic. Now, it is very difficult to estimate the beta, the transmission probability. Instead, we estimate R0. Once we know R0, we can indirectly estimate these 2. For the average rate of onset of infection disease per time step, we simply use this formula. So the rate equals 1 over average pre-infectiousness, so duration of pre-infectiousness. Similarly, we estimate the average recovery rate per time step, R equals 1 over the duration of the infectiousness. The estimation of these two just following this principle. If something occurs at a constant rate, the rate can be calculated as 1 over the average time to that event. So we just simply follow this principle. We know in epidemic, this assumption is very strong, and most of the occasion we could not verify them. But for any modeling, we have to make that assumption. Now, how can we estimate R0 based upon local epidemic? We estimate parameters at the initial stage of the epidemic. Now, this is what I did 16 years ago when I was in Hong Kong to model the SARS epidemic at different intervention scenarios. So we estimate parameters in the first 20 days of the epidemic. At that point, the epidemic growth exponentially. And at this point, there is no intervention, meaning this epidemic follows the natural history of the epidemic without the intervention. Consequently, the parameters you estimated during this period reflect the real parameters for the natural history of the epidemic. Now, first, we estimate growth rate. And this is data from a random county. And this is the log scale of cumulative cases. And you see that this line is linear. So basically, we just simply use linear regression to estimate the growth rate, which is the slope of the regression, 0.28. So the growth rate is 80% per day. Now, based on the growth rate, we can easily use this formula to estimate doubling time. You saw the doubling time presented by Dr. Liu 2 days ago. And this doubling time that measure the speed of the epidemic, which tell us it takes about 2.5 days that the number of cases would be doubled after 2.5 days. Now, based on these two numbers, we can estimate R0. I call this as quantitative approach. So we use quantitative approach, use these two formulas to estimate R0. So in the first formula, we get R0, which is 2.39. And the D is the average duration of infection is. Using the second formula, we get R0, which is 4.4. And the D prime refers to the duration of pre-infectious years. You can see that there is a large range between these two. Then you ask, what's the value I should use? Then I use an empirical approach. We are assuming at the beginning of the epidemic, there were 5 infected cases in this county. Then we use SGI model to answer these questions. What is the R value that leads to 150 reported cases during first 20 days of the epidemic? Then we use this model to estimate the R0, which is 2.77. Then we use this value with SGI model to predict the number of cases per day. So this is a projected curve, and this is reported cases. You can see that the two curves are highly correlated, meaning the projected data fit the reported data. The correlation is almost 0.9. So we decide to use 2.9, and also luckily the 2.77 is between of these two. So we simply use 2.77 as a reproductive number for a random county. Now, up to now, we have all of estimated values for the needed parameters. We simply use software to translate this equation into computer language. We use Berkeley Medana, which is specific software for modeling and plus Excel. Now, as I said, the reason we use model is not to predict the number of cases. Rather, we use model to help us to select the best intervention measures. Currently, in the epidemic of COVID-19, there are two strategies. The first one is mitigation prevention strategies. And this strategy mainly reduce the number of contacts per day, resulting and reduce R0. However, the R0 is still greater than 1, meaning we use mitigation to reduce R0. However, we could not stop the epidemic. The epidemic will continue in our community. The second scenario, the second intervention strategy is called suppression prevention strategies. And this strategy reduces the value of all of the 3 components of R0. Consequently, suppression strategy can reduce R so that it's less than 1. Consequently, this strategy can stop the epidemic and to eliminate human-to-human transmission. Now, what is mitigation strategy? I use this graph to document the meaning of this strategy. Say this is baseline epidemic, unmitigated epidemic without any intervention. Previously, we estimate R0, which is 2.77. So without intervention, you would see the epidemic curve like this. Clearly, in the county, this is the healthcare capacity. Clearly, the healthcare capacity does not meet the demand of the epidemic because a lot of cases in this area need to healthcare facilities. They need to hospital beds. They need to have ventilators or ICU rooms. Now, if we use a mitigation approach, we can reduce the peak of epidemic like this. This is so-called flatten the epidemic curve. Now, if we could reduce the peak of the epidemic, consequently, the existing healthcare capacity meets the needs because this curve is below than this one. And also, mitigation intervention strategy also push back the peak of the epidemic. Consequently, healthcare facilities or hospitals have more time to prepare for the epidemic. And one of the important mitigation measures is social distancing. That includes avoidance of large gatherings and physical contact to mitigate the spread and the impact of an epidemic. And this is the reason why we use social distance. The social distance, the purpose of social distance is to mitigate the epidemic. Now, under this intervention scenario, we model the epidemic against this is the natural history of the epidemic without intervention. Say, if Prince George used mitigation measures to control the epidemic so that R0 would be reduced to 2 from 3.35. Now, under this scenario, 97% of residents in Prince George County would be infected. On the peak date, 43,000 cases would be reported on May 8th. With this mitigated epidemic, the number of total cases would be reduced from 97 to 80. On the peak day, number of cases would be largely reduced. And also, the peak day would be pushed back. so that the hospitals have about 1 month to prepare for the epidemic. Now, if PG County Health Department take more rigorous mitigation measures, or if public comply the mitigation measures, the R0 would be further reduced to 1.5. In this scenario, about 60% of individuals in PG County would be infected. On the peak day, number of cases would be largely reduced to only 7,000. The peak death would be July 23. Okay, so this is a scenario for the intervention of mitigation, and a similar trend of intervention scenarios can be seen in Montgomery County. So during the first 20 days, we estimate R0 for Montgomery County, which is 3.55. Now, even with this better scenario, the R0 is still greater than 1, meaning the epidemic will continue. After mitigating effect, although the peak of intervention would be reduced, however, the duration of the epidemic will be longer than the natural history of the epidemic. Consequently, you would see the epidemic with us for such a long period. Now, what intervention we need to use in order to stop the epidemic? That is suppression prevention strategies. Now, this strategy aims to reverse or stop the epidemic through the following important measures. The first one is increased testing and contact tracing to really identify new infections in our community. The second approach, really isolate and treat systematic cases. The third approach is to massively use a mask in public. All of the three measures have been used in Singapore, China, and South Korea. Epidemic in these three countries have died out. We submit our report to the local health department and detailed these three measures in our report. Now, currently, some of the suppression measures have been used in the United States, except this one. In Singapore, the government, Singapore keeps people who tested positive in hospital and separates them from families. Now, at the beginning of the epidemic, both Singapore and China put infected cases in families so they do family isolation. However, later on they found the infected cases still transmit virus to their family members. In China, about 75% of cases came from the family transmission clusters, and later on they changed their intervention approach to put infected cases either in hospital or in hotel rooms so that they isolate the source of infection from our communities. Even though at this scenario, even we relax the social distancing, however, because in our society there is no official source of infections, we still reduce risk of transmission, even though we relax social distancing. However, at this moment, in our society, in the United States, there are so many infected cases in our communities. If we relax social distance, highly likely the epidemic would continue. And also, in order to reduce further transmission, we have to trace and manage at least 70% of close contacts. At this moment, I don't know the proportion of close the close tracing in United States. Once we have data, we can evaluate the quality of contact tracing at the county level. Now, under these suppression intervention scenarios, we would have epidemic curve like this. So in this scenario will involve 2 stages. In the first stage, we use mitigation to reduce R0 to 2. In the second stage, we use suppression measures to further reduce R0 so that it's less than 1, say R0 equals 0.8. In this scenario, less than 1% of population in the county would be infected. And on the peak day, only 182 cases would be reported on April 12. Now, if we put rigorous mitigation intervention on the first stage so that the R0 could reduced from 2 to 1.5, then we will keep the same scope of suppression interventions, then we would have this scenario. In this curve, epidemic curve, only 0.44% of population in the county would be infected. On the peak day, only 89 cases would be infected. Unfortunately, we could not see these 2 scenarios in Maryland because epidemic is still spreading in Maryland, and because R0 is still greater than 1. So this is our intervention goal. We try to reduce the R0 less than 1 by suppression intervention strategies. And similarly, we use a similar approach to display the intervention curves based upon the combination of these 2 strategies for Montgomery County. So this is the first part. So based upon all of these model analysis, we wrote reports and we submit report to the local health governments to give them suggestions or advice for the selection of the best intervention. Now, in the second phase, we evaluate the effect of social distancing. We select these 3 indicators to evaluate the effect of social distancing on the disease burden of COVID-19. The first one is called time varying effect reproductive number, RT. The second one is death growth rate, small rt. We also try to use quantitative measures to measure the level of social distance. So once our governor announced stay-at-home order, however, different counties may have different scenario of this. That totally depends on the compliance of our population. We try to measure this quantitatively. The formula for estimate the RT is very complicated. They use Bayesian approach. I skip this. So basically, R0 is similar to R0. R0 is the average number of secondary cases that each infected individual would infect if the condition remained as they were at time t. So basically, we estimate the different level of RT against the epidemic time. So the monitoring of RT over time provides feedback on the effectiveness of intervention and also indicates the needs to intensify control efforts. So basically, the R0 provides so-called real-time monitoring of the effectiveness of intervention. Now, I list this reference here. If you want to see how they estimate R0, you can see this reference. So we also estimate the case growth rate per day using this formula. When R naught greater than 1, the number of daily cases increase. It means the epidemic is still undergoing. When R naught less than 1, the number of daily cases decline, meaning you control for the epidemic. So the epidemic is under control. So our job is to reduce RT so that it's less than 0. Now, how we quantitative measure for social distance? There are several good indicators we can use. The first one is social distance index, which is actually developed by our faculty members in Maryland Transportation Institute. The second one, I would say the second one would be the most popular one, is called social distancing scoreboard, developed by a company called Anacast. The third one is mobility trend report made by Apple Map. The last one is called community mobility report made by Google Map. So our group, we work on this to see which index has high validity that can be used to predict the scope of the epidemic. Theoretically, the value of social distance can predict either decrease or increase the epidemic. If the index could not predict, the usefulness of the index is questionable. So we are working on this area. Unicast provides a metric called difference in encounter density. What does that mean? It just tells us how many of us gather together at a given time compared to the numbers before the epidemic. So they use the number of density as reference measured before the epidemic. The beauty of this index is this normalization. Usually the density is confounded by density of a population in areas. And this metric takes care of the bias caused by different population density. So we, in this present, we simply use this metric to quantitatively measure the level of social distancing. Now here is results. And this is for Orlando County. Look at this graph. So this is RT. And this line represents the number of RT against epidemic time with 95 confidence interval. You can see that the RT change against the time. So in Maryland, the starting date of stay at home ordered by our governor was March 30th. And after this, you see the R naught is reduced, as well as the growth rate. The growth rate is also reduced. However, it's still the 95 confidence interval is still greater than 0 for the growth rate. And this curve represents the difference in encounter density that measures the level of social distancing. You see that after March 30th, the density is largely reduced. And also before the governor claimed the stay-at-home order, there are also other measures. For example, close unessential business and the school closing happen somewhere right here. Now you can see that the R naught was reduced to 1.1 on May 1st from 2.78 on April 7th. So all of the three graphs indicate that social distance works in this county. However, there is a warning signal here. It seems that the public relax social distance in this area. And because the R naught is still greater than 1, And because people may relax the social distance measure, it is possible that the epidemic will continue in this country. And this is the results for Montgomery County. Now, also, I want to point this one. We use this approach to estimate R0 at the beginning, which is 2.77. This is very close to what we estimated by our empirical approach. In that approach, we estimate R0, which is 2.77, which is close to this approach. Now, in Montgomery County, still, you can see that after stay-at-home order, the RT reduced gradually. However, there's an increase here. So meaning on May 1st, the R0 has been reduced to 1.33 from 3.04 on March 26th. And also, the growth rate is also reduced. However, you see the large confidence interval here. And this graph also sent a warning signal here. People relax social distance in the recent several weeks. Right? Clearly, in Montgomery County, the social distance works in this county. However, because R0 is still greater than 1, and people may relax social distance in the future, the epidemic is likely to continue in this county. And also pay attention to this, there's a jump here. This could be due to the large coverage of testing, meaning the cases found here may not, the new cases, the cases may be infected with virus in this point, because at that time, they were missed because of the low coverage of testing. Once you enlarge your testing coverage, you are more likely to identify cases that was misreported before. And similarly, we see the effect of social distance in PG County. Again, however, the R0 is still 1.4, and the growth rate is reduced largely in this county. However, you see the confidence interval is pretty large, meaning growth rate may still greater than 0. And also there's large increase of the encounter density in Prince George. This is what we have for the state as a whole. The R0 was estimated as 3.23 at the beginning of the epidemic. After the stay-at-home order, the value of RT is largely reduced. However, it's still 1.21, meaning the epidemic will still continue in the state of Maryland, and the growth rate is reduced. However, you see there is a jump here, and the confidence interval is pretty large. And this is another warning signal displayed by encounter density. You see the people in Maryland relaxed themselves from social distancing. Now, even though the epidemic has been reduced to 1.21, however, on average, one infected cases still can transmit to viral to 1.2 cases. Given there are a lot of existing cases in our community, this number will still enlarge the speed and the scope of the epidemic. Now, in summary, because the reproductive number measured by R0 is still greater than 1 and social distance has been relaxed, the epidemic is likely to continue to spread in these counties and variants, although the scope and the speed of the epidemic has been largely reduced by mitigation intervention measures. Now, in order to curb the epidemic, the productive number must be less than 1. Therefore, more rigorous social distancing measures and suppression measures need to be implemented in Maryland. And in addition to the currently implemented preventive measures, Maryland needed to increase testing coverage. This has been done in Maryland. And timely tracing close contacts and effectively manage close contacts and asymptomatic cases. And these parts need to be done in Maryland. So testing and close contacts is a gateway to eliminate the infected sources in our community. If they could not be successfully managed, they will still serve as a source of infection in our community. Our job is to eliminate them from our society. Consequently, even though we relax social distance because in our community there are few or no source of infections, without social distance we still could not get the virus. Some limitations I need to mention here. The estimation was based upon reported cases, not infected cases. Consequently, estimated value would be conservative. The scope of the actual epidemic would be either large or smaller than the projected ones. And some assumptions in modeling are very strong, cannot be easily verified. So pay attention to interpret the results I presented here. Oh, thank you. I'm looking forward to your questions.
Thank you so much, Dr. Liu. The first question that was posed was by James York. He says, he was asking, don't you want to assume that some places like New York City have a higher R0 than more suburban regions? He's asking about differences in R0, R naught.
That's a good question. High likely is R naught in New York is higher than R naught in Maryland, because the scope and the speed of the epidemic in New York is much fast than they are in Maryland.
Thank you, Dr. Liu. On Wednesday, Montgomery County had mentioned that they were using 3 different estimates, 3 different estimation projections. They were including from Washington State. I think they also mentioned Pittsburgh, and they also mentioned ours, the University of Maryland, to help them make decisions. Can you talk a little bit about how these 3 different projections are different?
Well, the other 2 models use the same R naught, the same parameters to measure the scope of the epidemic for each state. In our model, we actually estimate the R naught, the modeling parameters, based upon the local epidemic in the first 20 days. You can see that different counties has different R naught at the very beginning. To me, I really don't think, for the other 2 models, they basically use the R naught estimated in China. I just do not know why they use this approach, given everyone knows the epidemic in China is totally different from epidemic in the United States. And to be honest, I believe the R naught estimated in China was 2.3. That is largely underestimated.
So much. The next question is, in 1 to 2 Scandinavian countries, apparently there was stronger actions to socially isolate older people from younger people. In your modeling experience, would this be an interesting strategy to model for Maryland? Pros and cons.
Well, now we could put one or more compartments in SGI model to separate the young population from old population so that we can create a second parallel model. So in the first model, we estimate epidemic among young population. In the second model, we estimate the epidemic for old population. And remember, there's a connection between the two models. We could do that, but we didn't do that because the more compartments we put in the model, the more assumptions we need to have. However, we know that most of the occasions, the more assumptions, the more parameters you put, the more unverified assumptions you need to put as well. Now, given we know the percentage of reported cases for old population, say our model generates 100 cases, and we know in reality about 70% of the cases are old population. We just use that percentage to estimate how many cases are old population.
Thank you so much. The next question is from Doug Ord, and he says, does the concentration of cases in relatively isolated groups, such as residents of long-term care facilities, affect the interpretation of these county-wide models?
Yes, yes. So again, that's a good question, and this is also related to the limitation of any modeling. For modeling, you have to use average. It's very difficult to model the different parameters for different populations. The epidemic among older population, especially in nursing home, is totally different from epidemic in our society because they are old, their immune system is not as strong as we are, and also they are live in a very isolated areas. Consequently, the epidemic can be easily transmitted within these special populations. That's the reason the governor, our governor, start universal testing for this specific population, and that is a good start.
Thank you, Dr. Liu. The next question is from Dr. Luisa Franzini. She says, what do you think will happen now that restrictions are being eased in Maryland and in neighboring states like Virginia?
Well, that's a good question. Even under the reopening of business, we still can keep social distance. Now, remember that currently we use a combination of different intervention approaches: social distance, testing, and treatment. Okay, say if we open our business, however, population, the individuals will still keep social distance. They still try to protect themselves from infections. Number two, we have testing. If we can test the infected cases to really identify them, to really treat them, and to really isolate them from our society, we still can reduce the risk of COVID-19 transmission. So with this combination of treatment, even under the condition we open the business, we still can reduce the spread of the epidemic. In other words, even though we relax social distance a little bit, however, if we increase the capacity of testing and treatment and isolation of the infected cases, the average of these two is still high. Meaning, we do not rely on one measure, we rely on combination of the measures.
Thank you so much, Dr. Liu. The next question is from Dr. Don Milton. He said, what do you think is the contribution of super spreaders? How might strategies that focus on identification and isolation of super spreaders be modeled?
Well, number one, occurrence of super spreader in COVID-19 is less frequent. We haven't seen a lot of super spreaders in the epidemic of COVID-19. Number two, regardless whether or not you become to be super spread, if we use testing to early identify all of the infected cases, and we put them in isolation, even they have the ability to transmit virus to others, to say without isolation, one person can transmit virus to 10 other people. However, if we isolate them through testing, we can still prevent occurrence of super spreaders.
Thank you, Dr. Liu. As you know, some of our students are interested in training and how to do this kind of modeling. What advice would you give to our students as to how to prepare themselves for this?
That's a great question. Remember, Olivia and I had a good conversation about this. So currently, Olivia offers a basic course for infectious diseases. The department is going to offer another high-level course on the epidemiology of infectious diseases for all of master students. We are going to offer this one. Clearly, there is a need for this new course. It's under our plan.
And the mathematical or statistical courses that students should take to help prepare them for a course such as this or future courses?
Yeah, we are planning a course for modeling in the future. And I believe our students take some basic courses in epidemiology and biostatistics. They can take the modeling course.
Dr. Liu and folks found it very beneficial to hear from our chief epidemiologist as well as the health officer from Montgomery County about what sort of skills, what sort of training you're tapping into to help you address this epidemic, this pandemic. Is there anything you would like to share that you're grateful that you had received that training or that education or that course or anything that you're drawing upon right now?
Well, that's a great question. This epidemic indicates that the public health system in the United States is weak, as well as education system. Now, in the past, we largely ignore the training of infectious diseases, and we focus on instead chronic diseases. And this epidemic reminds us we have to put emphasis on training our students in the field of infectious diseases. And our department is going to offer new courses. Number two, our school had a call for volunteers to work as contact tracers. And I sent this call for our students. I tell you, within 6 minutes, a total of 6 students answer this call and demonstrate their willingness to work as volunteer to provide their expertise in contact tracing. I was very moved and appreciate our students at this critical time they try to serve the country.
Thank you so much, Hongjie. We have one more question, but we're right at 11 o'clock, so you can decide whether you want to answer it or put a pin on it.
Last question.
Okay, last question from Dr. Steve Alt. He says, can you elaborate a little bit on the importance of family clusters in China, as seen as China, as you noted? Talk about family clusters.
Okay, that's a good question too. You know, at the very beginning, 75% of reported cases came from the family cluster of transmission, meaning 7% of reported cases had a history of contact with one or more family members who were infected with the virus. So once they test positive, they put the cases in the family isolation or family quarantine. However, they put the source of infection in the families. Consequently, the cases transmit virus to the family members. Later on, they changed their policy, and this is also true in Singapore. They put all of the infected cases, regardless of whether or not you have symptoms, put in hospitals or hotel rooms. And they sent community health workers to manage these positives. Basically, they measure their temperature twice a day and to interview them and to record any suspicious symptoms. So in this way, they isolate the source of infection from family, from society. Consequently, these suppression measures did work in the 3 countries.
Thank you so much, Dr. Liu. I'd like to remind everyone that our previous presentations are available online, both the slides and videotapes, and we encourage you to participate. We also are going to be reaching out to our colleagues who are providing services to various communities along the Americas as well as elsewhere, other epidemiologists, so we can continue this series, but we're going to put a temporary pause to take advantage of the time that faculty and students need to devote to doing final exams and getting grades in and that sort of thing. So we'll be taking this back up in the summer. Dr. Liu, any concluding remarks?
Well, thank you very much. Thank you for everyone who participated in this seminar. And this is our 4th series. We are going to have 2nd or even 3rd series in the future. Thank you all.